Hi guys, in today's video we're going to cover 50 high-yield must-know questions for your MSK exam. This is the last video in the series, so this will conclude every didactic class and as well as every EOR during your PA or MP education. So let's begin. Question number 1. Biphosphonates are used for what? So they're used for osteoporosis. So when it comes to the medications, if you already haven't taken any exams, you will find that they always ask you what is the next best step, or what is the most common, what is the next diagnostic test to order, what are the side effects of medication. So all of this is super high yield information. So knowing this will significantly improve your testing scores. So when it comes to biphosphonates, they are number one treatment for osteoporosis. Question number 2. What are the side effects of biphosphonates? So they're going to tell you in the question stem. So sometimes you just got to think about from the point of view of test creator, what is it they're asking you. So my advice is read the last sentence first in every question so you know what they're asking you. So that could be what is the side effect of this medication, what is the most dangerous side effect, what is the least likely side effect. Could be anything that they write, but knowing what they're asking you by reading the last sentence first will help you not get tripped by the long stem and so forth. So look at answers and see if it makes sense to you. So the side effect of biphosphonates is if it's used in IV, it can cause jaw osteonecrosis. And also do not use biphosphonates in the patients with GFR less than 35. So you can see from a test creator point of view how they can play with this. They can tell you it's an inpatient that was diagnosed with osteoporosis with a DEXA scan, and they're going to ask you which one of these medications side effects is the most severe, and that would be jaw osteonecrosis if it's used in IV. Or they can tell you in the question stem something like this is a patient with a kidney disease that has a really bad GFR, and at what GFR level we should not be using biphosphonates, and that would be if the GFR is less than 35. So biphosphonates used for osteoporosis can cause jaw osteonecrosis if it's used in the IV, and they're not used if they're less than 35. So which medication should not be used in the patient with osteoporosis? So in this question stem, they're going to list different medications. They're going to ask you which one of these is contraindicated, and that would be calcitonin because it can increase the risk for cancer. So calcitonin not used for osteoporosis. Question number 4. So what is the T-score for osteopenia? So they're going to give you a DEXA scan with different T-scores, and they're going to ask you, does this patient have normal, osteopenia, osteoporosis, and so forth. But so to know the T-score of -1 to -2.5 is considered osteopenia. Anything less than -1, like -0.9, that would be considered normal, and greater than -2.5, like -2.6, -2.7, and so forth, would be osteoporosis. Question number 5. What is the most common fracture seen in Paget's disease? When it comes to the Paget's disease, it's always the vertebral crush fracture that is the most commonly seen with the Paget's disease. Question number 6. What is the most common cause of septic arthritis? So in the question stem, they're going to tell you this patient comes in with a swollen joint. You suspect this is a septic arthritis, and they're going to ask you what is the most common bug causing this. That is Staph aureus. So Staph aureus likes to go to joints. It makes a septic. So septic arthritis, Staph aureus. So SA for SA. Septic arthritis, Staph aureus. SA for SA. That's another tip I can give you guys is create a little mnemonic, create little stories that can help you significantly retain information faster, because when you're taking an EOR, you're looking at 120 questions in 2 hours. During the didactic is like 40 questions in an hour, and then for your PANCE you got 300 questions. So little stories like this significantly help you retain the information and recall it faster. So SA for SA, septic arthritis, Staph aureus. What is the most common location of the septic arthritis? And we already said that they like to go to joints, so it'll be a knee and a hip. What is the most common organism in acute osteomyelitis? So again, you can see this most common locations, most common causes. This is super high yield stuff. So most common organism in acute osteomyelitis, again, Staph aureus. So in the MSK, Staph aureus plays a big part. So septic arthritis, osteomyelitis, think of Staph aureus. Question number 9. Which incontinence is seen in Cara equina? So they're going to give you a question stem when a patient comes in severe low back pain. radiating bilateral posterior ties. They're also going to have that saddle anesthesia, and they're going to talk to you about patients got incontinence, bowel and bladder issues, and they're going to tell you which of these incontinences is most commonly seen in cauda equina. They're going to list different incontinences, but you're looking for overflow. So overflow, cauda equina. Alright guys, so all of these questions can be found in my book, PS Study Buddy for Didactic Year. It has all of these questions, just like the other videos. We'll cover 50 high yield. So there's about 4,000 questions or so just like this. I just wish I had something like this when I was going through PA school, because this is how I studied, just the high yield stuff and just my study guide from class, and I just had like no issues with the testing, and it was just, yeah, it made it a lot easier. So also, for those of you that are new to the channel, take a look around, see if there's other helpful videos. Hit that subscribe button, help me grow this channel, tell your friends, and let's continue. Question number 9. Tenderness at mid-foot tarsal metatarsal joint should always make you think of Lisfranc fracture. So in an x-ray, you're going to look for that step off. So this is going to be usually a runner or somebody going to tell you they got that like mid-foot pain, and you should be thinking about Lisfranc fracture. And here's a picture. Okay, so you can see right here, this should be, these two black lines should be perfectly aligned for a normal foot, but there's a step off. That is the step off they're talking about. And the way I remember this one is, if they're talking about step off, if they're talking about foot injury, I just ask myself a question: who stepped off? And I would be Liz. Liz was running, and Liz loves to run. Liz stepped off. Lisfranc fracture. Liz stepped off. All right, let's continue. Question number 10. Inversion of the ankle can damage which ligament? So they're going to tell you somebody stepped off the ledge, or they stepped off while they were running, or they inverted their ankle, and they're going to ask you which one of these ligaments is most likely involved, and that would be the lateral ligament. And the way I remember this one is just the word ill, I-L-L. Inversion, lateral ligament, ill. So when somebody hurt their ankle, they inverted, I was like, oh, that's ill. Ill. I-L-L. Inversion, lateral ligament. Question number 11. This thing decides to work. Oh, here's a picture of the inversion. So you can see the lateral ligament, and this picture is inverted. That's awesome. So yeah, inversion, lateral ligament. Question number 11. Jones versus tuberosity avulsion fracture. So they're really close in the location. They're going to tell you a patient comes in, they have like this lateral foot pain, and they're going to even show you an x-ray. But the Jones fracture, what you should remember, is a high yield. Jones fracture is about 1.5 centimeters above the tubercle. Avulsion is the most common. Jones can progress to necrosis, are the two other high yield stuff. So they're going to ask you which one of these lateral foot injuries is the most common. That would be the avulsion fracture. And if you're looking at a Jones fracture, just think about 1.5 centimeters above. So here in this picture, you can see, where's my mouse? Here we go. So this is avulsion fracture in purple, and then Jones is the metaphysis. So you can see about 1.5 centimeters above, we're talking about Jones fracture. Everything above that would be a stress fracture, and then tuberosity is right down below. So that's how you differentiate those two. Eversion of the foot can damage which ligament? So they can see from test create strategy, this is, they can give you a long stem to kind of trip you, but knowing that eversion and eversion have different effects on different ligaments. So when it comes to the eversion, that would be the deltoid ligament, and I just remember the first three letters: deltoid eversion ligament. ILL for inversion lateral ligament, and DEL for deltoid eversion ligament. Boxer fracture. What is the treatment for boxer fracture? They're going to come and tell you patient has, a hand pain, they punched the wall, they got in a fight, something, there was a closed fist punch, and the treatment is ulnar gutter splint. So that's another question that you can see, different splints, different casts, and which one is used for what. So that is of course high yield. So for boxer fracture, we're talking about ulnar gutter splint. 14. Bilateral burst fracture of C1 is called what? So when it comes to the C1, you should be thinking Jefferson's fracture. So this is an unstable fracture, and the orthopedic or neurosurgical team should be consulted. So bilateral burst fracture of the C1, Jefferson's fracture. C2 fracture is called what? C2 fracture is called the hangman fracture. So C1, Jefferson, C2, hangman fracture. So it's like associated in the past with people hanging, they would break their C2, so that's where the name comes from, C2 hangman fracture. Number 16. Most common bug associated with osteomyelitis involving puncture wound of the foot. So in this question stem, you'll likely see something: the patient was running, they stepped on a nail, so something penetrated the sole of the shoe, bringing all that bacteria from the sole, from that sweat, from everything that's in the sole of the shoe, into the bloodstream and into the bone. So the most common associated with osteomyelitis involving the puncture is Pseudomonas. So runner stepped on a nail. It's usually the stem that you'd be pimped on. Oh, that's another thing. All this high yield information for your clinical year, you will likely be pimped on all this high yield information during patient presentation, could be during rounds, and so forth. Question 17. Radial head subluxation should make you think of nursemaid elbow. So nursemaid elbow, radial head subluxation. What ligament is involved in a nursemaid elbow? So they're going to tell you this is a young kid that comes in, they hold in their hand, they don't want to move. You suspect on an x-ray you see the radial head subluxation, and they're going to ask you which ligament is likely involved. They're going to list different ligament, and that is the annular ligament. And the way I remember this is nurse, so nursemaid elbow, nurse and for annular ligament injured a child. So nurse and injured a child. So anything that has to do with a nursemaid elbow, I just think of nurse, name Anne, that injured a child. And for annular ligament, child is the population that is affected by nursemaid elbow. Question number 19. Most common age group for slipped capital femoral epiphysis, SCFE. So when we're talking about different presentations, knowing what specific age group is associated with that is super high yield, because once you see a question stem, they'll usually start, this is a 12-year-old boy or 14-year-old girl, and they're going to give you the rest of the stem. So knowing that what age presents with different things, it can be significantly helpful. So when it comes to the SCFE, we're looking at anywhere from 7 to 16 year old, so like adolescent. Usually will be obese kid, and they're going to be presenting actually most likely with a knee pain and a limp. So another high yield is every time the kid presents with a knee pain, you should be looking at their hips as well, because hip radiating pain goes down to their knee, and they'll likely have a limp as well. So if the kid just comes in and say, I have a knee pain, you should examine their hip as well. So the range of motion will be decreased with the SCFE, and is treated with the open reduction and internal fixation. So ORF is a treatment for SCFE, and usually it's a young obese kid. All right. What will the x-ray of the SCFE show? So this is anonymous with the ice cream slipping off the cone. So if you have a 12-year-old obese kid that comes with a knee pain, you examine their hip, you're going to see a decreased range of motion, and then an x-ray will show you that slippage. You can see it right here. So this is the ice cream slipping off the cone. So here's a picture of ice cream slipping off the cone. Basically, this is where the bone happens, and this is how it looks on an x-ray. So ice cream slipping off the cone, SCFE. All right, 21. Osgood-Schlateler's disease is located where? So when it comes to the Osgood-Schlatter's, that is the anterior tibial tuberosity. This would also be likely in the runners, really active kids. Treatment is rest, ice, NSAIDs, quadricep stretching, and is the most common cause of chronic knee pain in young active adults. So it's another high yield. They may ask you what is the most common cause of the chronic knee pain in young active adults, and that would be Osgood-Schlatter's, anterior tibial tuberosity. Congenital hip dysplasia is seen with usually the firstborn girls. So that's like the high yield. You'll see this is the firstborn girl comes in and has got this like, you know, balance or hip issues, and they're going to ask you what is the most likely cause, and that would be congenital hip dysplasia. Avascular necrosis of the proximal femur. So avascular necrosis of the proximal femur is Legg-Calvé-Perthes disease. So Legg-Calvé-Perthes disease, you should be thinking proximal femur, and you should be thinking avascular necrosis. And there's a picture of it, so you can see an X-ray. Of course, everything is flipped, so this is the right side, this is the left side. So you can see the left proximal femur has got that avascular necrosis. It was not fully developed. It kind of just looks like all mushy. So this would be considered Legg-Calvé-Perthes disease. All right, let's continue. You guys doing great. What is the most common benign bone tumor in children? So they're going to give you a question stem with different bone tumors, and they're going to ask you which one of these is benign and the most common in children, and that would be the osteochondroma. So osteochondroma, these patients will usually present with that painless mass, and it's the most common located in the metaphyseal region of the long bones. So a kid will come in and says, I really don't have pain, but there's like this mass, and it's just like bugging them. It can be like rubbing against their jeans. It could be different reasons, but usually the key word is painless mass, and this is osteochondroma. And on an X-ray, you can see the growth on the side of it, usually long bones, and that is osteochondroma, most common benign bone tumor. All right. Question number 25. Most common malignant bone tumor. So we already covered the benign, but now malignant is osteosarcoma. And most commonly, osteosarcoma metastases will go to the lungs. So that's another question they can ask you. They're going to tell you this is a kid that had a bone tumor. You're going to show an X-ray presenting osteosarcoma, and they're going to ask you, when it comes to this tumor, where do mets most likely go to, and that would be lungs. So lungs, osteosarcoma. Osteosarcoma X-ray will show what? It will show the sun ray burst. And here's a picture. You can see it just kind of looks like a sun ray burst. If you look at the sun, it's got this bursts out. Same here. And the way I remember this is there's nothing sunny about osteosarcoma. It is the most common malignant bone tumor, and when it comes to the sun ray burst, I just remember there's nothing sunny about osteosarcoma. So any question about osteosarcoma, I'll just say there's nothing sunny about osteosarcoma. That indicates that it's a sun ray burst, and it's the most common malignant bone tumor. There we go. Question number 27. Ewing sarcoma X-ray will show what? So osteosarcoma will show sun ray burst, and an Ewing sarcoma will show onion skin. And the way I remember this is just ow, ow, like ow, onions, ew, ew, that's nasty. Nasty onions. Ew, ew, onions. Ew stands for Ewing sarcoma. And here's a picture. You can see osteosarcoma will be the sun ray burst, but here we can just see like the onion skin on the sides of the bones, so that is indicative of Ewing sarcoma. 28. This fracture is usually seen with ski accidents, twisting fall. So question standing, you're going to see the patient got to the urgent care at the ski resort and so forth, and the reported patient fell down and it was just twisting as he was falling down, and that is always tibial plateau fracture. Another high yield information about tibial plateau fracture, it is the most common cause of compartment syndrome. So they can ask you a question about compartment syndrome. They're going to ask you which one of these fractures is the most commonly cause of compartment syndrome. It's tibial plateau fracture, and it's usually the ski accident with a twisting fall. Pain at the radial aspect of the wrist should make you think of what? So the pain at the radial aspect of the wrist is the Quervain disease. So this is usually a new mother lifting the baby all day long, and you're going to see that positive Filkenstein test. That's when they put the thumb in a hand and you twist it down, and they say they have the pain at the radial aspect of the wrist. So that's the Quervain disease. Finkelstein test will be positive, and a stem will likely say this is a new mom or somebody who does a lot lifting with their hands. 30. The Querian disease, inflammation of abductor pollicus longus, and which other ligament? So yeah, you can see from a testing point of view, they can play with these ligaments, they can list them. So when it comes to the Querian disease, it is extensor pollicus brevis and pollicis longus. Most common cause of cauda equina. So when it comes to cauda equina, we already covered the 3 big signs you should be looking for. That is bowel and bladder issues, saddle anesthesia, and a bilateral posterior thigh radiating pain, so like a S1 radiculopathy. And the most common cause is acute disc herniation. So this could be somebody who was doing like a deadlifts, lifting something super heavy like a heavy object, and they just got immediate pain, overflowing continence. So yeah, acute disc herniation. Cauda equina findings. We already kind of mentioned this. Bladder dysfunction, saddle anesthesia, stool incontinence, and also on a physical exam, they will have an absent anal wink. So anal wink, or if it's absent, you should be thinking cauda equina, and this is a neurosurgical emergency. Neurosurgery should be consulted for immediate surgery. Most common shoulder dislocation. So knowing different dislocations of different joints and which direction they go is super high yield, because they are caused by different mechanisms of action, and that makes it easy to make a test question. So knowing that most common shoulder dislocation is anterior shoulder dislocation, and when it comes to the posterior, this is usually seen with the electrical shock and seizures. So if they talk about shoulder dislocation and in a stem they say the patient had a seizure, you should be thinking posterior. And if it's just a normal, like sports-related accident, you're usually seeing anterior. And it's like 95% to 5. So only about 5% of people experience the posterior. And here's a couple of pictures. So the posterior shoulder dislocation will have that light bulb sign. And you can see it kind of looks like a light bulb. So if you see this on your x-ray in your stem, you should be thinking posterior shoulder dislocation if they don't mention anything about seizure or electrical shock. So the light bulb sign is associated with posterior shoulder dislocation. And then a second easiest way for me to differentiate anterior versus posterior is to look at the Y view. The Y view on the x-ray. I did 14 years of radiology before PA school, so I really enjoy this, and I enjoy teaching radiology in different PA schools. So if your school needs a good radiology course, have them contact me and I'll be happy to do it for them. So if let's go back. You can see the Y view, and then you just basically see what the head is doing. If the head is leaning towards the ribs, and it's not right down the center, it's normal. If it's leaning towards the ribs, that is anterior, and if it's going away from the ribs, that would be the posterior dislocation. Okay, let's continue. Anterior shoulder dislocation can affect which nerve? So they're going to tell you this patient came in after a football game, they got the dislocated shoulder, they're going to ask you which of these nerves will likely be affected, and that would be the axillary nerve. So think about shoulder, axillary, anterior shoulder, AA, anterior shoulder axillary nerve. So I just remember AA, so anterior axillary. Most common type of elbow dislocation. When it comes to the elbow, the most common type is posterior, and the mechanism of action is going to be FOOSH, full on outstretched hand. That's a term you will likely see a lot in the MSK. So FOOSH, full on outstretched hand with hyperextension. So they fell down, they try to catch themselves, and they got a posterior elbow dislocation. Spilled teacup sign on x-ray should make you think of what? So if they talk about, they may show you an x-ray, and they may not say spilled teacup sign, or they may just say in a question stem the radiology reports a spilled teacup sign. So this would be a lunate dislocation. So when it comes to the spilled teacup sign on x-ray, you should be thinking lunate, and you can see here's the lunate, the bone, and instead of sitting up nicely with the rest of the bones aligned, it is off to the side, and it looks like a spilled teacup. So yeah, that's just, one of the funky radiology signs. One of the ways I remember this is I was sipping on a tea and I was watching the moon. So moon being in Spanish luna, so that makes me think of lunate. And when was I drinking the tea? When did I spill my tea? Well, I spilled it while I was watching the moon. So spilled teacup sign, lunate. Luna, moon, drinking a cup of tea, watching moonlight. That's how I remembered it, never forgot. 37. Most common cause of hip dislocation. So when it comes to the hip dislocation, most common cause is trauma. So it takes a lot to dislocate a hip. It's a big joint, and to dislocate a hip, there's some kind of trauma involved, usually. So that would be the most common cause. What is the most common type of hip dislocation? When it comes to the hip dislocation, again, it will be posterior. So shoulder anterior, elbow posterior, hip posterior. Which artery can be ruptured in tibiofemoral dislocation? So if you dislocate your knee, you're likely going to be affecting the popliteal artery. So popliteal artery runs in the back of the knee, so if there is a dislocation, we can rupture the popliteal artery. Number 40. Most common location for herniated disc. So most common location would be L5-S1. So L5-S1, most common location for herniated disc, and acute herniated disc could lead to cauda equina. Osteomyelitis, most common bug is Staph aureus. 42. Most common bug in prosthetic joint infection. So when it comes to the prosthetic joints, it's different bugs. So if it's just, septic arthritis, it's Staph aureus. But if it's prosthetic joint infection, then it would be Staph epidermis. So Staph epidermis. And I would just remember for prosthetic joints, I said, do you need an EpiPen for that prosthetic joint? If the prosthetic joint is hurting, just like for anaphylaxis, I just think EpiPen. So for prosthetic joint infections, I would just remember myself and say, hey, do you need an EpiPen for that septic arthritis? An EpiPen, epi in it reminds me of epidermis, Staph epidermis. I just look for any epi in the answers, and usually it'll just be one Staph epidermis, and you got your answer. Prosthetic joint infection, Staph epidermis. Do you need an EpiPen? 43. What is the best test for osteomyelitis? To be sure this is osteomyelitis, you're going to need an MRI. Absent patellar reflex is what nerve? And that would be the L4. So in the question stem, they say you did a physical exam and there's an absent patellar reflex, that is an L4 nerve. What's gamekeeper's thumb? So when it comes to the gatekeeper's thumb, this is a sprain or tear of the ulnar collateral ligament of the thumb. Instability of the MCP joint. So gamekeeper's thumb. So if there's your thumb involved, the ulnar collateral ligament will be affected, sprain or tear. So if they're talking about thumb, I just think ulna, and I think ulnar collateral ligament. Gamekeeper's thumb treatment. Well, you're going to treat it with thumb spica and a referral to the hand surgeon. So in an urgent care, you're going to put them in thumb spica or an ER, and you're going to refer them to the hand surgeon for further diagnosis and treatment. 47. Fracture of which bone can cause wrist drop? So a patient comes in and their wrist is just dropped, and they're going to ask you which bone fracture is most likely a cause of this, and that would be the mid-shaft humerus fracture. So if you see an x-ray and there's like a mid-shaft humerus fracture, these patients can have a wrist drop. 49. When it comes to the wrist drop, you should be thinking about injury to which nerve, and that would be the radial nerve. So you can see how they can play with the question stem. They're going to say, they may even show you a picture of the mid-shaft humerus fracture. They may tell you this is the wrist drop, and they're going to ask you which nerve is likely involved, and the answer is radial nerve. Or they're going to say, a radial nerve injury in the mid-shaft humerus can present with what? In that case, the answer is wrist drop. 49. Positive empty can test. So positive empty can should make you think always of the rotator cuff tear, really high in differential diagnosis. So empty can, rotator cuff tear, and number 50, bamboo spine should make you think of ankylosing spondylitis. So ankylosing spondylitis, bamboo spine, easy one to pick. So any mention of the bamboo spine, AS, ankylosing spondylitis. Alright guys, that brings us to the end of this video. I hope you enjoyed this video. I thoroughly enjoy MSK. I love teaching radiology. So leave a comment. Let me know what you think about these videos. Do check out the other ones. There's one for every class. Check out a book. Let me know what you guys think. It really helps the algorithm if you leave a comment and hit that like button. And I'll see you guys in the next video. Take care.